Thanks.
Welcome back to the afternoon session. So we will be going straight into the next session, which will be chaired by Mutale. Just before we do that, I'd like to give an announcement. There are two sets of forms that the conference delegates who will be doing the PCR testing need to fill in advance. So those will be shared with you during the session. So kindly ensure you fill in all the details just to prepare for your test, which will be starting from 15:30. And as indicated, you will be guided out of the room. The test will be done a delegate at a time. Thank you. We'll get started. Is my microphone on? I hope I'm audible. Welcome to the after lunch graveyard session. One of the panelists is yet to join, Dr. Mthethwa. But in the meantime, because we're short on time, we'll already get started. This session is looking at unconditional cash transfers and access to social services. We have making presentations this afternoon. We have Dr. Zulu, Dr. Isaac Chinyoka, and Dr. Edmos Mthethwa. We'll be beginning with Dr. Zulu, who is the research manager at SPI. He's got broad research interests and is interested mostly in socioeconomic justice, gender, and human rights. He's currently overseeing various research projects undertaken by SPI, including the basic income grant. He'll be talking to us this afternoon about social protection responses in SADC, a review of current and future cash transfer programs in the wake of the global economic and social disruptions. And then after him, we'll have Dr. Isaac Chinyoka, who is a South African Chair on Welfare and Social Development Research Fellow for the Center for Social Development for Africa at the University of Johannesburg. I see Dr. Mthethwa is making his way up. Dr. Mthethwa is currently a senior lecturer in the Department of Social Work at the University of Zimbabwe, where he obtained his doctorate in social studies, disability and public policy, and an MSc in social work. So Dr. Chinyoka will be talking about thank you. Dr. Chinyoka will be talking about the limits of transnational influence and cash transfers in Botswana. And Dr. Mthethwa will be talking about, he'll be talking about the efficacy of the harmonized social cash transfer program in alleviating poverty in Zimbabwe. So I'll go straight away and invite Dr. Zulu to take us through his presentation. Dr. Zulu, please.
Thank you. I've taken off my mask. It's fine. I try to keep my social distance. So yeah, my paper is based on social protection responses in SADC. It's a review of current and future cash transfer programs in the wake of global economic and social disruptions. So the paper is based on the research that was done, primary and secondary research that focused on social protection cash transfers and in SADC. Next slide, please. Do we have the slide? I'll move that. Right. Social protection responses in SADC. We are going to look at the review of current and future cash transfer programs in the wake of global economic and social disruptions. What are we talking about? The aims and objectives of the study that was done looked at identifying the effects of cash transfer programs on individual and family behavior and attitudes. Because when we talk of cash transfers, we're not talking of cash transfers in isolation. They have an impact, not just at the societal level, but at individual and family level. So that's what one of the things that we looked at identifying. To identify the impact of cash transfer programs on poverty reduction and community development. The primary objective of our study was to consolidate existing knowledge of social cash transfer programs, the policy formation dynamics, but also to look at the lessons for social protection policies within the SADC region. In looking at that, there's an acknowledgement that there's a growing recognition that cash transfer programs can be appropriate, effective, and flexible tools to eradicate poverty and reduce inequality. So that is something that is not in argument, it's not for debate. But what the key for us is, in doing this, there's the issue of maintaining dignity, promoting choice and empowerment to vulnerable income groups. I'll come back to this point of promoting dignity and why I think it's a very valid point that we need to put across. Because I was listening to the previous presentations. There was a focus on political willingness. There was a focus on the implications of that for states, the economic implications. But I think one of the things that we tend to miss is to what extent do the cash transfers make a difference in people's lives, in people's being. So I'll speak to that. So this is based on the premise that when livelihoods are suddenly disrupted, like as we saw with COVID, poverty and inequality, which is rife in SADC, can be alleviated or reduced more effectively where there are pre-existing income safety nets, which exist in the form of a universal basic income grant that can be targeted or humanitarian transfers. So if these already exist, like what was rightfully pointed out in some of the case studies that were done prior to my presentation, there's already a mechanism that people can already tap into and move with. The argument that we make in this one is that a functioning sound protection system that embeds basic income as a fundamental human right to the benefit of all who reside in the SADC region should not be reduced to handouts to the poor. Again, in that point that I was referring to, that of dignity. So it's a fundamental human right. But this should be rather conceptualized and accepted as a developmental policy mechanism to promote economic justice, reduce poverty and inequality, and thus also speak to the issue of socio-economic rights. It can stimulate human and economic integration, as well as harness social cohesion across our porous regional borders. I think South Africa has seen the value or the disadvantage of the porous borders, but also the disadvantages of how other failed economies can affect your economy if your economy is looked at as a success. So if we talk of BIG, I'm not going to define the terms on BIG. Let's focus on social security. Like I rightfully mentioned to you, this came from a study that we did on SADC, and there was a primary research was a special focus on Namibia. The work is a combination of both primary and secondary data. A pilot study on Namibia basic income grant was conducted, and we did the primary research and spoke to a number of people in academia, in the government, and also in the civic society. Common to the findings that we found was the recipients of the grants reported improvements in their physical and mental health. Participants were more healthier and in good spirits. I think this is some of the things that we tend to take for granted. I'll come back to this point about, because in Africa, more often than not, sadly, mental health is not a big issue. Either we ignore it or we choose that it doesn't, we pretend that it doesn't exist. Yet it's a big fundamental problem that affects everyone. There was improved health and healthcare with more use of public healthcare system. When you make public healthcare accessible, people then can go and seek services. But if it's inaccessible, if there's a price to pay for that, then it makes it difficult. Already that creates a barrier of access. In South Africa, I think the last time I checked, Citizens could pay 40 Rand to go to the public hospital and all of that, but non-citizens have to pay to attend that. So again, that can then be discriminatory. There was a general increase in household food security from improved nutrition and diet. So now when people have an income, they have a choice on the food that they eat. They have a choice on the diet that they have. So that then allows them it creates food security, but it also creates an increase in nutrition and diet. There was a general increase, improvement in housing stability and social relationships, where people have money and don't have to worry about the usual day-to-day issues. There's a general improvement in social relationships. There was improved school attendance from school-going children. Again, this is a factor that tends to be missed in terms of policy or missed in terms of academic settings, where we don't understand how poverty affects even becomes cyclical, becomes generational, where because of poverty, then the family, everyone else has to put their hands on the till to try and get something for the family, for whatever's going to be eaten. So this then affects school attendance. So we realized that with grants, with the social protection system that was given, it improved the school attendance because families had something to eat and children could go to school. The other findings that we found was the financial status of beneficiaries improved. And that improvement in their financial status allowed them to engage in other economic activities without necessarily focusing on survival. For me, this is key, because more often than not, the people that are making arguments against the enactment of BIG, basic income grant, the argument is that it will make people lazy, it will make people don't want to work and all of that. It's not true, because findings reveal that once people are given something, then they look for more. People will always want more to improve on their lives. So it's a fallacy to claim that the people don't, if you give them a grant, then they want to work. I think the fallacy, the misnomer, is where we think that when somebody doesn't have food to eat, what else do they think about? So if the focus is on getting food to eat, it's indignifying, it's injustice. For example, increased labor market participation and continued working to supplement the cash transfer they were receiving. There was improved economic participation, which led to more entrepreneurial activities by beneficiaries. Evidence showed that women's financial independence did improve, freeing them to find and engage in other economic activities that were dignified. I'm not going to mention the other economic activity that sometimes that women are forced into, sometimes just to maintain survival for themselves and for their kids. But when their grants are given, then they can engage in other economic activities that are dignified. I'll stop here. Thank you.
Thank you very much. We'll move on to Dr. Chinyoka to do his presentation. You have 10 minutes, Dr. Chinyoka.
Well, thank you for the time to make this presentation. My focus will be on Botswana, where I'm trying to look at the limits of transnational influence on cash transfer in that country. So I'm sure you would agree, we have already had a lot about Botswana this morning, but you also agree that in much of Africa, most of the cash transfer programs that you see have been into, the expansion, even adoption of those programs has been influenced by international donors. Of course, the same for a few countries like South Africa. But if you look at the programs that you find in Zimbabwe, in Zambia, we read about Zambia, Mozambique, in Malawi, most of those are cash transfer programs that you find they are influenced by international donors. And these donors have come up with some evidence to show that poverty targeted cash transfers really have an effect on people's well-being. But we don't seem to see this in Botswana. So this is where my question comes in to say, Why is it that at a time when we're expecting, the influence of these international donors in other countries, why don't we see the same happening in Botswana? How do we explain that? We have heard about in Uganda, donors coming in, but why is Botswana a bit unique? Next slide. So we might want to place Botswana in the general understanding of how do we see cash transfers within the region in terms of provision. So if you look at South Africa, the major programs are pro-poor. I use the regime type of understanding social provision in Southern Africa, but I just give you examples here. But when you look at countries like Zimbabwe, mainly these are agrarian. It's an agrarian regime because it's agricultural focused, it's agro-based. Although we might want to know that most of these countries started, they were all agro-based, but then they shifted. And if you look at Botswana, Botswana is more of a conservative welfare regime in that, the focus is mainly on family. In as much as other countries like Zimbabwe also focus on family, but in Botswana, their understanding of how to assist the vulnerable is much more focused on the family. But of course, if you look at Namibia, you kind of find a mix of pro-poor, because most of the programs that you find there look more or less like what we find in South Africa. But of course, we find the familial focus, because also there's this understanding that, yes, in as much as we look at individuals by having cash transfers for different categories, we might want to have also programs that focus on the family. But if you, so for us to have a good understanding, I think we should look at what is the character of social policy in Botswana. So I just look at the three aspects here, which is the targeting part of it, which I've already talked about. The interest here is to look at a family breakdown and how those people in broken families can be assisted. Next slide. Then of course, there's no deliberate interest in focusing on poverty targeting, and also the emphasis in Botswana is on welfare. But in terms of generosity, you see that there's there's a lot of there are a lot of programs. I'm sure Prof. Mthethwa in the morning told us that there are about 10 programs that are social transfer programs. But in terms of all of those programs, what you find is that there is the in-kind benefits are very generous when it's compared to the cash transfers. But of course, they are so parsimonious in terms of the cash transfer of the cash itself. So when you talk about cash transfers or social cash transfer in Botswana, we have to know the disparity between the cash itself and in-kind benefits that they give to people. But of course, when you look at the overall coverage, we can see that there's low coverage. There's an argument by other people that, but we see some programs which are universal, like the school feeding program is universal, it covers all children, but it is only one program. When we put together, the overall coverage becomes very low. But let's look at some examples of how these donors that we're talking about, vis-a-vis this character of social policy in Botswana, what international donors tried to do in terms of reforming cash transfers and manage to some extent. That is why I talk about the limits. So let's look at two programs. For interest of time, I'm just going to look at two programs, and then we'll make some conclusions. The first one is the Orphan Care Program, which was the next slide, which was introduced in 1999 through this was government. It's a government program, but this is a program which was mainly influenced by USAID And USAID was very instrumental also in the uptake and the reforms that came later after 1999. In terms of targeting, this program was mainly targeting orphans, up to about 2007. So it started in 1999, but up to 2007, it was then expanded to cover orphans and other vulnerable children. So USAID and other donors were very influential in moving or in changing the focus on orphans only to include other vulnerable children. So as you can see, I argue here that the success, for lobbying the government to expand the coverage is something that we can, which we can talk about, which you can notice, post 2000. But it doesn't mean that this is what donors want. It doesn't mean that donors only wanted to expand the program to orphans and other vulnerable children. What the donors really wanted was to have a universal child grant. And they also wanted to have something like this child support grant that we see here in South Africa. And that gives cash. So those were the major proposals. But again, they also wanted to shift from the narrow definition of what the Botswana government defined as orphans, because it only covered a very few number of children. So if you look at these proposals, there was, we could actually say that there was failure to influence the government to introduce a universal grant, and also despite the success in targeting reforms, the ultimate goal of introducing a poverty-targeted cash transfer was not achieved. Then the last program, which I want to look at, next slide, please, is the family support grant, which was proposed by the World Bank in 2013. This was going to, if it was introduced, this was going to result in a shift from cash, from in-kind to cash. And also, it was going to be a poverty-targeted grant. And this program then will replace programs, existing programs that we find in Botswana, like Prof. Mthethwa said, 10 programs that we find there. So, but this program was not adopted, despite World Bank, working together with UNICEF, trying and USAID as well, trying to push for this support, the cash transfer program, the family support grant. But if you look at the name itself, it reflects how donors were trying to introduce a program that fits the way the government, the familiar approach, because this was going to be a family support grant. It was not going to be for individuals. But so what do we conclude from all these, from the failure of donors to actually influence the government to introduce a poverty-targeted grant, to also introduce a cash grant, because most of the programs that you find in Botswana are in kind. Like when I started, I indicated that, the conservative ideas of family, work and dependence, like in Botswana, the emphasis is on workfare. This is where, what we see in most of Africa. So this is kind of, this tradition, we see it more in Botswana, in the conservative welfare ideology in Botswana. And because of that, we see that the persistence in this conservative welfare ideology, even when these donors are pushing for rights-based programs, we don't see the influence, because the focus in Botswana is more on the conservative side. And of course, just to conclude, we need to understand that if these cash transfers were introduced, we could have more coverage, we could have more reduction in poverty. But so we need to embrace pro-poor programs, so that, which are also rights-based, so that we can have more coverage and reduction in poverty. Probably we could talk more about Botswana in the discussion.
Thank you very much. Thank you, Dr. Chinyoka. Dr. Mthethwa, if you're ready, you can talk to us about your presentation on the efficacy of the harmonized social cash transfer program.
Thank you very much. Chair led him. As has already been said by others, your cash transfer programs, come in a number of ways. They normally come in the form of provision of either money or, some in-kind, assistance to individuals or even to households. And either as some kind of an emergency relief, in the context of Zimbabwe, or simply just to address, basic needs, as some kind of recovery support, particularly in terms of drought. I think a number of scholars have conveniently classified them into conditional and unconditional. That is fundamentally important, in the ensuing discussion. In the context of Zimbabwe, Zimbabwe has got what we call the Harmonized Social, Cash Transfer Program, SACT, which is a product of shared responsibility between, the government of Zimbabwe and, your non-governmental organizations. And, the Department of Social Development, housed within the Ministry of Public Service, Labor, and Social Welfare, bears the overall charge or mandate, of coordinating this program, in terms of the Social Welfare Assistance Act, which is the law governing, the implementation of the same. And the indications are that from the trend, the Harmonized Social Cash Transfer program is poised to become Zimbabwe's permanent or primary social protection program. As it provides cash to the most vulnerable households across the country, targeting largely or mainly labor constrained households, and that are also food insecure. Because of that, I sought to evaluate the efficacy of the Harmonized Social Cash Transfer program being implemented by the government of Zimbabwe and development partners. The motivation behind that was some considerable empirical evidence gleaned from literature to the fact that the Rwanda, which is the research district, is one of the poorest districts in the country. The bone of contention, undergirding the study is that even though cash transfers have really been heavily marketed and popularized as a remedial measure against the scourge of poverty, in developing countries, their efficacy remains rather hazy, particularly, in poverty-stricken districts of Zimbabwe. I'm not going to speak much to the methodology, but just suffice it to say, we employ the mixed methods with a very small population, though, just to, drive the point home. May I also just next slide. Okay. In terms of findings revealed that cash transfers here were, largely capable, of cushioning beneficiaries, against the ultra poverty, as shown by, some positive social and economic returns realized by, beneficiary, households. That included, among others, improved livelihoods, improved access to health and education, as well as the ability to embark on, income generating projects. With respect to targeting, it is worth my emphasis that transparency builds, the required social capital, within communities, impacted by, the program, thereby contributing towards achieving, the desired goals, of alleviating poverty. And in this regard, a number of people, particularly 70 or 47% of my population, agree that the selection process, was above board. They were happy with the, selection process, but the 42% even also indicated that the process was fairly transparent. At the same time, 11% had reservations. They had their reservations. And testimonies also, from the even participants and the respondents interviewed indicated that cash transfer, increased household per capita income, by more than 40%, whereas significantly reducing household food expenditure. The cumulative effect of this was a rise in child school attendance, as the beneficiary families were able to save some modicum household income than they were able to do before benefiting from the program. And in this context, I think the social transfer programs have become, an asset, and have become some kind of, a huge social and economic investment in the future workforce, of the country. Program beneficiaries, further reported that their capacity to invest in income generating activities, increased significantly, thereby, catalyzing their subsequent graduation, from the program itself. Consequently, beneficiaries were able, to channel, some of their financial resources, towards other productive ends, like, the purchase of fertilizers, seed, and the related, productive assets, thereby protecting themselves against food insecurity. Similarly, it was also revealed that the cash, transfer program managed to reduce, income inequality. It also reduced the number of, population groups living, in general extreme poverty, and the health conditions of beneficiaries also even improved. It was further shown that there was an increase of almost 50% in the amount of fraud purchased by those families previously, enjoying, food insecurity. On a similar note, the majority of respondents revealed that the cash transfer program succeeded in enabling them to acquire fixed assets, to start some kind of their small enterprises. So it is my case that contrary to conventional wisdom, cash transfers are in no way meant to perpetuate, and promote, as well as deepen dependency, from on the state by beneficiaries. They should not be seen or looked at from a charity lens. Rather, they should be looked at in terms of the social, investment sort of, lens. I thank you.
Thank you very much. Thank you to all the presenters. Sorry I had to rush you, but I'm under strict instruction. No, I'm joking. Yeah, so we have to make time. I'll invite quick questions. Let's make them pointed in order for us to make time. I'll invite Gift over there. Please raise your hand and go to your nearest mic when acknowledged.
Is the harmonized cash transfer still operational? Just needed to know that.
Thank you. If we have anybody from Secretariat that's taken note of the online questions, if any. Okay, do we have any other questions? Yes, please. Please go to your nearest mic. Anyone else with a question?
Hello, my question is also for Dr. Mthethwa. As you were rounding off, you were saying that you just want to emphasize that cash transfer shouldn't be seen as handouts, but for the most part, like people outside of this context and space still perceive it as such. So what effort do you think can be made to destigmatize that association with cash transfers? Thank you.
Okay. Thank you. I see no more hands. Dr. Mthethwa, your question.
Thank you. My answer to the first question. I think maybe putting one the other yet. I'm also of late, maybe from June or so, July. I was appointed Chief Director for Social Development and Disability Affairs in the Ministry of Public Safety and Social Welfare. In that context, I would just simply, my answer in the first person will be yes. Then to the second question, the only way to stigmatize the recipient of social cash transfers or the recipient of simply welfare assistance, or social assistance in general, is to popularize the belief, or rather the positives of the program, which positives lie in the fact that this program has enabled the children to go to school, thereby building human capital, and combating extreme poverty. It has enabled the communities to be productive, because of the investments that they put into, the surplus of it is put into, other productive units such as the, agricultural, the purchase of agricultural machinery and related products. Last but not least, the fact that there is a general propensity for the recipients of such kind of cash transfers to want to earn more has resulted in them, coming up with small projects that they fund out of those cash transfers. So it is my humble belief that if we take that road, we will be able, to by and large destigmatize the social cash transfer. Thank you.
Thank you very much. Do we have any questions from the online participants? If none, I see one more hand. And then after that, I'll just ask the other panelists to, if they have any thoughts, to please make your way to the mic.
Thank you. I don't know, mine is more of a question, but also a comment. I think in terms of from the discussion from both the first presenter and the second one, and doctor, I think what we need to realize that social protection needs to be universal for us, for everybody to appreciate it. Because I was just looking at how, why, for instance, in Africa, we are poor. Even when you're in gainful employment, you have to subsidize the other social protection cover. So if these social welfare, these grants given to our poor people or persons, or the indigent, or those elderly persons, are to be seen as an investment rather than charity. It will come in having maybe more discourse on how the investment in social protection actually also frees up income for even private sector, for those employed in either public service or other businesses, because they negate this role of having to look after their poor relatives. Maybe we need to have that discourse, and more research is done on how, for instance, I was comparing, if an engineer works in Belgium, where I was a student, they are earning 2,500 euro in most cases. Uganda now, use Ugandan because I live in Uganda now. We have Ugandans earning 7 million Uganda shillings, which is almost equivalent to 2,000 euro. But still, because they have to pay for education very expensively, whereas the counterpart in Belgium is paying nothing, they have to pay for fuel and public transport very expensively. The counterpart is paying almost next to nothing. Education, health, which social protection measures we don't have here. So it means everybody is poor, because by the time you spend on all those, you have nothing left. So we need maybe to look at it that way. That way, even policymakers will understand that social welfare is to everybody's benefit. Thank you.
Thank you very much. Valid comment there, and I think also touches on destigmatizing social cash transfer programs as handouts. I'll start with you, Dr. Zulu.
Thank you. Thank you, Dr. Mthethwa. I want to go back to the point that I referred to in speaking to maybe the question of how do we destigmatize the issue of cash transfers. Maybe let's be more radical. Let's criminalize poverty. Dr. Mthethwa, this is a challenge to you from one countryman to the other. Let's criminalize poverty. Let's make it criminal for leaders to have people within their constituencies who are poor. Because when we do that, why I'm saying let's be radical about that. Because the indignity of suffering and thinking about when your next meal is going to come from should not be visited upon anyone. None of us who is a member of the human race should have the indignity of worrying about their next meal. When am I going to have my next meal? What am I going to eat? And all of that. But we have that among our societies. Worst of all in Africa, worst of all in SADC countries, worst of all here in South Africa, where there's sometimes it's virtually two worlds in 100 square miles of land, Santon and Alex. But that, because why I'm saying this is because the indignity of having to worry about your next meal can be taken off by the grant. So the grant then should be a right. That removes that indignity of having to worry about it. It guarantees food on the table. And that does, sorry. Once it guarantees food on the table, then that's when we can speak of even the kids going to school, because those kids are not going to be out there begging on the streets for something food to be put on the table, right? Then we can have the multiplier effect that all my colleagues here and everyone else has been talking about, that once people have a little something, there's dignity in that. The next thing they're going to, we all aspire to a good life. We all have aspirations for more, for better, and all that. But if we remove the indignity of having to worry about our first meal, then we'll have conquered this issue of poverty. That's
Thank you
my
very much.
closing
Perfectly
statement.
said. I think we need to get radical. Yes, Dr. Chinyoka, please.
Okay, thank you. I would like to make a comment on Gifty's question, which is about the HST in Zimbabwe. I think Dr. Mthethwa said that yes, the answer is yes, but I'm sure we should point to the fact that this program has not expanded as it was planned. And probably what our interest should be, why? You know, because what we know about that HST program, it is similar to Zambia's program. It is also similar to Malawi's program. It is also similar to Mozambique's program. And apparently, Ben Schubert is the person, the consultant who designed all those programs for all the countries, you know, focusing on labor-constrained households. But we still continue to have labor-constrained households. But in Zimbabwe specifically, this HST has actually been reduced from covering, say, 9 districts or 11 districts. At some point, it was even covering like 3 or 2 districts. So I think we should be asking ourselves, why is it reducing? Is it poverty is reducing, or it is because there's no funding or there's no political will? So I think that those are the questions that we need to talk about. And then the other question was, how do we start thinking about universalizing this program so that we because the agenda 2030 and 2063, when you're looking at poverty, the idea is to make sure that we have legislated provision, making it a right for everyone to be able to claim, social protection and social services. But, how do we do that is the question that we must be asking ourselves. So if you think about the argument in South Africa to have a basic income grant, and also in Namibia as well, that there was some talk and even some pilot programs to start thinking about, should we have a basic income grant? We are looking at how we can improve in terms of coverage, but not only coverage, but for us to make sure that it becomes a right. And as we speak right now, it is in Southern Africa, it is only South Africa where social protection is legislated, is in the constitution. So what should we learn from that? And how can you move forward?
Thank you very much, Dr. Mthethwa. Any last thoughts in a minute?
Thank you. Just to point out a few issues that, for any program to be sustainable, it must not be donor-driven. the experience with Zimbabwe is that the Harmonized Social Care Transfer Program was initially donor-driven. But in all areas where donors pulled out, government stepped in. And that's why I said the program is indeed there. On a similar note, I think the aspect of coming up with the basic income, grant and the legislating for social protection as a right. I think the Constitution of Zimbabwe, Section 30, I think is very clear, about the social, protection, as a basic right. At the same time, being aware of probably the side effects that are still debatable in academia, and in practice. That probably, if not properly done, it can also even create work disincentive. I still maintain that. Thank you.
Thank you very much. Okay, so thank you very much to all the panelists. Thank you for making this a very interesting discussion and keeping everyone awake after lunch. Quite a well-debated conversation, so thank you very much. Please let's give them a hand as the next member of the platform. Like a true African leader, I'm going to hold on to a chair for a little bit longer.
There was an American who tried to do that.
True. So it will be Africa plus one. Yeah, the true Africa plus one leader. So move straight into the next panel. Where we'll be joined by Mpho Sekwakwa, who will be joining us virtually. Dr. Charity, who is also joining us virtually, I think. And Dr. Nicolas Otieno, all joining us virtually. They'll be talking to us this afternoon about, firstly, Dr. Mpho will talk to us about, is Dr. Mpho replacing Dr. Knox?
Hello, can you hear us?
We're having two presenters for this session, right? Only two.
Can you hear us here?
Sorry about that. So it will actually be Mpho and Dr. Charity doing one presentation, and Dr. Otieno Ajwang doing the second presentation. Dr. Knox is unable to join us because he's currently unwell. So the first presentation by the two ladies will be on social protection responses in SADC. Okay, that looks similar to the one that we just had. Dr. Otieno will be talking about.
Hello.
No, that's also similar to the one we just had. Sorry about that. So if I may just already introduce the panelists, and then they'll share with us their presentations. Mpho is a proactive in implementing social protection legislation, policies and programs through provision of social work services to patients, families and communities for enhanced social functioning. So the title of this session is Universal Access to Health Coverage. I'll invite Dr. Charity and Mpho to please take the podium. So you have 10 minutes for your presentation.
Hello, can you hear us? Can you hear us?
Yes, we can hear you. Please go ahead.
Okay. All right. Yes, we are putting on the screen. We are trying to put on the presentation. Good afternoon.
Good afternoon, thank you.
Afternoon.
Is the screen visible that side? Is the screen visible that side?
We can see
Hello?
your slide. Yes, we can see your slides.
Okay, thank you.
You can put them in
Thank you.
presentation.
Afternoon, everyone. I'm Mpho Sekwakwa. I'm based in Sekwakwa Memorial Hospital in Serowe, Botswana. So I would like to share my presentation this afternoon. The presentation layout is as follows. Would first start with the introduction. The project objective, the overview, data collection method, research findings, and analysis, evaluation, recommendations, reference. Then we'll just give a highlight of the video of our group work process. The presentation intends to give an overview of group work therapy on poor adherence to highly active antiretroviral therapy, HART, by children aged 13 to 15 years in Serowe District Health Management Team. It was conducted from April 2019 to September 2020. But initially the project was to run for a period of 12 months. Unfortunately, we experienced challenges due to COVID-19. Hence, it lapsed to September 2020. The aim of the group work therapy was to improve their social functioning and capacitating them to overcome their challenges effectively on a daily basis as service users of antiretroviral therapy. The research question was, what holistic approach can be done to improve adherence to HART by teenagers aged 13 to 15 years old? The project objectives were to explore challenges experienced by teenagers who poorly adhere to HART, to provide effective intervention services aimed at improving the social functioning and capacitating them to overcome their challenges effectively on a daily basis, as well as to improve members' interaction, communication, and cohesion in a group setting through group work activities. The overview, children form part of the vulnerable groups, and a human immunodeficiency virus, HIV status, even make them more vulnerable. In Serowe District Health.
Mpho, if you could
Hello?
please scroll through your presentation, because we're still at the layout.
Okay. I will just cut through it. I will just give you the statistical reflection of children on HART. Number of children who defaulted HART in Serowe in 2018. There were a total of 276 children on HART, and there were 66 who were defaulting HART. One may ask as to why we focused on the target group of 13 to 15 years. Although the statistic shows the highest number of defaulters from the age of 16 to 18 years, President and Nqobile assessed that when children transit from childhood stage to teenagers, they need emotional resources in order to have stamina to withstand difficult and uncomfortable situations and feelings, and also to aid them in healthy development. Hence, we focused on the age group of 13 to 15 years. The group that was facilitated was a growth group, which is meant to offer opportunities to members to become aware of, expand, and change their thoughts, feelings, and behavior regarding themselves and others. The data collection method, the project adopted both the quantitative and qualitative data collection approach. The data was collected from the hospital database, social work assessments tools, that is the intake sheets and questionnaires, and a total of 10 participants who were poorly adhering to HEART from the age of 13 to 15 years were enrolled in the group work therapy. Participants were drawn using purposive sampling methods, and data was analyzed quantitatively.
For research findings and analysis, we did a group interview, 3 group interviews that we conducted to determine the needs of the members. Our need assessment was done through a root cause analysis using a fishbone model that we adopted from the Ministry of Health Work Improvement Team manual. Then we have the fishbone diagram as reflected on the screen. The fishbone diagram reflects the causes and the effects. The causes are those that we came up with the group members that we had as to what they perceive to be what influences them to adhere purely to HEART. We have the manpower, we have the machinery, we have the environment, the methods and the materials and the measurements. Then we categorize according to the numbers as reflected. And then the cancelled ones are those that the members felt that it doesn't lead them to default treatment or to adhere poorly to treatment. Then, next slide. Then we linked the focus topics that we formulated from that root causes. We had the focus topics, we had self-esteem, we have responsibility, we had communication, adherence, goal attainment, and family relationships. Then we linked them to the variables that we were measuring, which were the understanding, disclosure, adherence, stigma, belonging, and peer fatigue, and self-esteem. So this diagram here, the bar graph shows the variable assessments that we were doing, then with their marks according to how the children performed during the group therapy. When you look at the bar graph, you can see that at the end of the group therapy, most of the variables attained 100%. Then we had the adherence progress, which was the summary of those variables that we were doing. Then our target was 90%. We started with a baseline of 74.2%, and we progressed to the final adherence of 97.8%, which was the group performance.
Mpho, you have 2 minutes.
Okay, we'll then move to evaluation. On our evaluation, during the beginning phase, members were not participating freely, but as the group progressed, they showed improved interaction, communication, and cohesion with one another. There was improved adherence, behavior changed, and group members reflected growth in their social skills as the group progressed. Feedback from other group members with similar circumstances provides that the opportunity to change thoughts, feelings, and behaviors towards adherence and social functioning. The recommendation: children who are on antiretroviral therapy are prone to emotional distress. Therefore, Their esteem needs should be met in order for them to have positive self-concept and self-image. Like other methods of social work intervention, group work should be facilitated frequently to improve social adjustments as it established suitable environment for members. Group work as the key intervention method of social work should be monitored with design tools that measures service delivery. Then we have the reference page.
Thank you very much, Mpho. Will you be ending with that?
Thank you.
Thank you. So I'll now invite Dr. Otieno, who will be talking to us. We'll be looking at an analysis of free maternal health care policy in Kenya. Dr. Otieno? Ajwang?
Okay, thank you so much. Let me share my screen. I want to believe that I can be heard. I don't know, can they see my screen?
We can see your screen.
Are you able to see my screen?
We can see your screen.
Okay, thank you so much. Now, okay, thank you. Thank you. I'm going to be very brief. I'm so glad to be part of this conference. And my presentation, as has been said, I'm looking at actually the aspect of maternity healthcare in Kenya, which is free. And the WHO defines maternal health as the health of women before and during pregnancy, at childbirth, and during the postpartum period. And that is very important because many times we might just assume that maternal health is only about the aspect of giving birth, but it's a whole spectrum. So according to the UN Population Fund, a woman's chance of dying or becoming disabled during pregnancy and childbirth is closely connected to the social and economic status, the norms and values of her culture, and the geographic remoteness of her home, because some of the health facilities that they can actually access are far away. It knows that the poor are more marginalized. Women are at greater risk. Yeah, and so it is this it knows is well reflected on maternal mortality rates, and you can see the disparity between the rich and the poor nations. And mostly in sub-Saharan Africa is where you have many of the many pregnancies or child deaths compared to the developed countries or the developed world. So considerable efforts have been made to ensure skilled birth attendants in many parts of the world, including also in Africa. The aim is to reduce morbidity and mortality among mothers and newborns, with substantially improved number of births in health facilities. Now, the Kenyan government introduced the FMS, Free Maternal Service, in the year 2013. And this was done through a presidential proclamation after a general election in 2013. And so it was made possible for women to give birth in public health facilities for free. But there is the progress in reducing maternal deaths is still slow, and this was found from a research that was conducted locally. Many pregnant women still cannot access maternity services before, during, or after birth. Yeah, and this is due to cost. So the government decided to increase access to use of maternal health by introducing FMX, that is free maternal services. Now, this service, it received a lot of widespread support, especially among the marginalized communities and then non-urban communities who can now access free maternal services. However, it was hard in implementation, and this presented so many challenges to health facilities and policy beneficiaries. Now, the policy has been widely taken up by pregnant women. It has increased the number of facility deliveries. Yeah, now people not delivering at home, but in health facilities. Additional funds from the program, because the funds are sent directly to to the public hospitals that the women attend to. So the fund is sent there. It has helped to improve maternity units, through hiring of staff, equipment, and also supplies. Now, increased demand for services is one factor that has happened. Now, there is congestion, insufficient equipment and staff, increased staff workload, working many shifts. There is strained facilities, congestion in wards, sharing of beds, less attention to mothers and babies, and sadly also early discharges where people give birth and go. You come in, you give birth, and you walk away. Now, formal policy on free maternal health services needs to be developed, and I'm giving the recommendation, indicating what services it covers, because sometimes there's confusion in when it began, up to what level is the government paying that is free. So there is need to be a clearness on this, and implementation arrangements and procedures for monitoring and evaluating should also be put in place, that we're able to monitor and evaluate the service, that it is actually functioning. Accountability mechanisms to verify utilization reports and reduce the potential for fraud. Because when the government sends money to the county hospitals, because the health facilities are devolved. So the national government sends money to the county hospitals that take care of the pregnant women, and also the few national hospitals that we have, around 3 national hospitals. So there is no mechanism to verify utilization. So there's also need to engage key stakeholders, and this includes county governments, who actually own most of the public health facilities that the government, that the women attend to. And then in conclusion, I want to say that there is consistent reimbursement to facilities. That one is there. There is continuous registration of mothers in the system when the mothers they report, but also seamless referral system in the FMS is what I find also is not really working well, because you find that, for example, a pregnant mother reports in hospital A, and so is registered in A for FMS. But again, A decides to transfer her because maybe of the critical nature of the pregnancy to B. Now, the mother is forced to pay in B because he had registered in A. Now, the government is going to send money for her treatment in A, but the money is not going to follow her in B. Okay, so there is some of these things that needs to be checked. Thank you. Okay, yeah, I can still say the FMS has made it possible for pregnant mothers to access maternal care in public facilities for free. Yes, this has improved health care. It has then, but we need to synchronize the national government and the health government in provision of health care for women in terms of maternal health care. Thank you so much.
Thank you very much, and thank you for sticking to time. Do we have any questions? I'll invite the audience to ask any questions, clarifications. I see there's two comments in the chat. I'm not too sure that they relate to the presentations. If there's anybody keeping an eye on that. Yeah, in the meantime, yes, we have one question. Please go ahead, make your way to the mic. Any more questions in the room? You can draw close to the mic that's closest to you if you have a question.
Okay, my question is directed to Dr. Otieno. Thanks for your presentation. I found it very interesting because I'm also into maternal health care. I wanted to ask you, you're talking about the importance of stakeholder engagement, and you talked about the county health departments, but what about like grassroots levels, such as like traditional birth attendants, because some women, even though there's removal of user fees, but they still prefer, going to like local birth attendants, and perhaps sometimes they don't perceive the quality of care in the clinics, as good as the local birth attendants. So yeah, I wanted to ask in terms of like the efforts to integrate those type of people in the system. Thank you.
Thank you very much. Anyone else with a question? Or shall I invite Dr. Otieno to respond to that question? Dr. Otieno, please go ahead.
Okay, yeah, thank you so much. Thank you for the question. One thing we can say is that the introduction of FMS actually has pushed many women now to abandon the traditional forms of maternal care, so that now they go to the hospitals actually to seek now the what we can refer to as the Western form of maternal care. So you realize the traditional forms are actually dying out. The traditional midwives, now the women will prefer to go to the hospitals because now it is free for them. Meaning, actually, the issue of cost is what was pushing them to the traditional forms of maternal care. Thank you.
Thank you very much. I don't see any more hands, any more questions? If our online guests can see the questions and they're directed to you, you can please take that up. But if not, I'll invite you just to say something quick in conclusion, if you have any points that you'd like to emphasize. I'll start with the ladies, Mpho and Dr. Charity. Any key takeaway points from the ladies?
Come again.
If you have any key takeaway points that you'd like us to listen to in a minute from you, please go ahead.
Okay.
If not, I'll invite Dr. Otieno to just give us a quick, any points that you'd like to make in closing.
Okay, yeah.
Okay, please, Dr. Otieno, please.
Yeah, thank you. I thought Charity was on the floor. Thank you so much. I just want to say that actually for my presentation, the issue of FMS, free maternal health care is important in Kenya. It is working and it needs to be supported more and to be synchronized from the national level to the county governments. Thank you.
Thank you very much. So that brings us to the end of this session. You can thank me during tea break because I've just earned you some tea break. We didn't have that in the program. So yeah, but thank you very much for your attention. I'll invite Secretariat in case there's an announcement, but in the meantime, we'll break for tea for 15 minutes. Susan?
Thank you, Mutale, for taking us through the two sessions. So we will now take a break. So the time now is, what's the time? Okay, I do not have the time with me, but the next session will be starting at 16:10. The next presenter is available then because that was what was communicated. 25 to 4? Oh, okay. So we will be back by 4 o'clock. Is that fine, Naka? Okay, we will get in touch with the next presenters so that they are ready. You will note that the last 2 sessions, this is session 5. Session 5 and session 6 had a typo error. Apologies to the speakers for that. There was a typo in the program. This will be updated in the soft copy version of the program. So sincere apologies to the speakers as well as to the session chair. I think it was confusing during the session. So we will come back at 16 hours. And as mentioned, we've earned ourselves some tea break. So you could either stretch your legs or have some tea. I'm still full from lunch. I do not know about the physical attendees, but it's also an opportunity to just network. So to the virtual participants, we will be back at 16 hours. Thank you very much.